Welcome back. This is Dr. Massey, and we're going to be continuing on with the lumbar spine examination. Starting off our chart review, our patient interview, using that to generate a list of probable diagnostic hypotheses that we'll continue to uh, try to eliminate throughout the course of our examination. Screening questions that can be important. Those screening questions that we want to ask about, they can be suggestive of a serious or non-musculoskeletal health condition, like the history of cancer for cancer, that is, and smoking history as well. Weight loss, fatigue could be related, also could be getting into infection as well. Bowel and bladder dysfunction, sexual dysfunction, lower extremity paresthesias, anesthesias, saddle paresthesia, anesthesia. Um, really wanting to consider neurologic dysfunction, especially Cauda-Equina syndrome. History of infection. So remember in the health conditions lecture, talking about how history of infection can be concerning for our other infections, fever, abnormal sweating. So again, those questions that we want to consider for possible infection. And trauma, other contextual factors that increase uh, probability for specific non-musculoskeletal health conditions. So red flags have been studied. This Cochrane review specifically in regard to red flags for malignancy for patients with low back pain, that is. And again, this study looking at the overall diagnostic properties of these different different red flags here, really finding that there's not a single red flag that can be found that can help us be totally sensitive in finding this health condition. So that being said, clinical reasoning is essential. So finding multiple red flags, also other contextual factors that come into play. So diagnostic and prognostic information that we'll gain, talked about that much more thoroughly in our health conditions lecture. Common functional limitations that you'll see for folks with mechanical low back pain, lifting, bending, especially bending over and lifting up from the floor, but also with bending, common functional tasks like donning the shoes, tying the shoes and socks, pulling up pants, squatting as well, getting all the way down, extension activities, especially if we're talking about our facet arthropathy or other degenerative arthropathies, twisting at the trunk as well. And again, these just being some common functional limitations that you'll hear, and you're likely to hear different things with your patients, but commonly we'll hear these. So outcome measures specific for the lower back, the patient-specific functional scale. So again, that scale that's not limited to one particular region and can also be used to help track progress over time with different functional limitations. Our Oswestry Disability Index, our Roland Morris questionnaire, which I know you've talked about in research. Different psychosocial outcome measures can be really helpful as well. And we'll talk about the FABQ and the use of that tool for determining if someone is appropriate for a manipulation procedure, a spinal manipulation procedure. But there's much more utility than just that alone. Finding these psychosocial disorders can be really instrumental in knowing how we're going to approach our patient in regard to communication, even. Pain catastrophizing scale, Tampa scale of kinesiophobia. Again, these not carrying a stigma on a patient so much as helping guide us in how we can best communicate and be most effective with that particular patient.